Okay, we'll continue with the cardiovascular again, and this time we will talk about the conditions that affect the internal structure of the heart. And the first condition we'll talk about is the infective endocarditis. Now, just a quick reminder of anatomy and physiology. As you know, the endocardium, so it's an endothelial that lines the heart from the inside. The significance of the anatomy and physiology of the endothelium is that it's connected to the heart valves. So any problem in the endothelium, whether infection or inflammation, can affect the valves. And you know that the valves are gates for the cardiac output. So any problem in the valves will lead to complication that's related to cardiac output problems, like decreased cardiac output. And the other thing you want to know, again, valves, the closure and the opening of the valves is what's causing the heart sound. So when there's a destruction or there's a problem with the valves, then you will hear extra heart sound or murmurs. So that will explain why a patient with endocarditis, for example, will show murmurs. Okay, so again, because the endocardium is the inner layer of the heart and because it's connected to the valves, that's why it is a serious problem. Okay, so by definition, infective means there's a condition that's caused by an infection of a microorganism. Endocarditis, ITIS, means inflammation. So this is an inflammation of the endothelial layer that's caused by a microorganism, which most commonly is a bacteria, but it can be caused by viruses and also by fungi, but most cases it's caused by bacteria. Now, where do these bacteria come from? Now remember, the blood is sterile, so there's no microorganism in the blood whatsoever. So these microorganisms will have to come from somewhere. They probably a normal flora, like the normal flora in the mouth or in the skin. And whenever there's a breakdown in the skin and exposure to the blood vessels, these microorganisms will manage and they get to the blood stream. And they travel with the blood and go and stay by the valves. That's the area they like, and by the endocardium, and then cause the problem there. So with that said, now that should make sense when we talk about who's at risk. So IV drug abuser, for example, their risk is 60 times than the regular population. And again, this is because of the continuous invasion or continuous breakdown in the skin and the IV with using the IV drugs. So the microorganisms that live in the skin, it's normal flora. It's harmless. But if it's reached to the blood or any of the internal structure of the body, then it becomes harmful. We notice that male more than female again, and this you may have to do with more male than female or drug abusers. Replacement of heart will put the patient also at this risk. Dental work, because again, the streptococci bacteria, which is the most common agent of endocarditis, they mainly live in the mouth. So with poor mouth hygiene and poor mouth care, and with a dental procedure that may involve cutting the gum and exposing the blood vessels, the risk is very high. That's why later we will talk about, for any patient with high risk, every time they have dental care or dental procedure, they have to receive prophylactic antibiotics. Now, a patient with congenital heart disease and cardiomyopathy also at risk for this problem, which is the infective endocarditis. Okay, pathophysiology, again, the simplest pathophysiology. This is an infection that causes an inflammation. But the clinical manifestation will depend on where this inflammation is taking place. Now, again, the most common causing agent we said will be bacteria. So bacteremia means that the bacteria manage to get into the blood. As a result of that, they go with the blood flow and they stick to the endocardium, and which is close to the valves, and they start to build and grow in that area. This growth is called vegetation. So when the bacteria manage to survive and stay next to the endocardium and cause them growth and colonization, it leads to what we call vegetation. This is a key word. Vegetation, if you hear that word, especially when it's reported by an echocardiogram, which is the test of choice, That means that confirms that there's a bacteria growing in that area. Now the problem with vegetation is that it can break off, and that will generate or creates emboli, and that is a serious or one of the serious complications of endocarditis. So first, the calcification of valves will make the valves opening narrow, and that can lead to decreased cardiac output, and so the patient will show symptoms of heart failure and fatigue. But also the thrombosis is a serious thing. Now thrombosis, it can this emboli will travel and may cause problem in wherever they go, and occlude the blood vessels. Now if the problem is in the right side of the heart, like in the tricuspid valve, the right side of the heart is connected to the pulmonary circulation, so the emboli will travel and cause most likely a PE. So if you have a patient comes with the endocarditis, we see it by the tricuspid valve, then you have to keep an eye on this patient, and if the patient ever develops dyspnea, that's an indication that this is a pulmonary emboli or pulmonary embolism that was caused by an emboli that was broken off from the vegetation. If the problem in the left side, it's even more serious, because the emboli will leave the aorta and may go to the brain, cause a stroke. It goes to the heart, maybe to the kidneys, to the spleen, and so on. So this embolization is a serious complication that you have to keep an eye on your patients. Again, if the valve is completely destroyed and now the cardiac output is pretty compromised, patient will show symptoms of heart failure. In fact, the most common complication of endocarditis is heart failure if the valves were destroyed as a result of the endocarditis. So let's understand the manifestation again. Here's we have an infection, so we know what the signs of symptom infection: fever, chills, leukocytosis. And if this infection complicated and becomes secondary, again because it's by the heart, but it can travel in the blood and cause sepsis, or septicemia, which is infection of the blood. The growth of the bacteria that cause the vegetation again increase the risk for emboli, and we talked about what the complication that can be as a result of that. And if they break down again into a very small emboli, they travel to the peripheral vessels, and that can lead to classical symptoms that you only see it in endocarditis, and it's actually an indication of late stage endocarditis, like splinter hemorrhage and Osler's nodes. I will show you some pictures. And again, the third thing, if the valves are involved now, you will hear murmur, and a new murmur always is a serious thing. Decreased cardiac output as a result of destruction of the valves. And because of the valves, these valves are in between the atria and the ventricles, so they are close to the AV nodes. If the damage is serious and it's reached to the AV nodes, then you will see dysrhythmia like AV blocked. So let's see some of the pictures. This is what this is the vegetation, a growth of bacteria, as you can see here. So these areas, if it breaks down, it will cause emboli. This is what we call the splinter hemorrhage. Again, this is as a result of small, it's a hemorrhage as a result of this whole reaction of endocarditis, but also the emboli can also go and close the small blood vessels. The Osler nodes are, again, as a result of the reaction to the endocarditis, is an immune reaction, and it's small thrombi that can cause ischemia, and that's why it's painful. The ischemia is caused by the small blood vessels, small emboli that came from the vegetation, and you will see it in the hands and feet. And then the other one is the Janeway's lesion. This is an immune reaction, and you see it. This has to do with the skin more than the blood, and that's why it's painless. It's more of the skin dermatology problem. You will see it in the palm and soles, as you can see in these pictures. These lesions and nodes, there are also again sign of late endocarditis. What does that mean? It means like if you have the patient early on and we start antibiotics, but we still see these symptoms, that means antibiotics are not working, for example. Roth's spots also, which is a retina hemorrhage. Again, that's another symptoms that you will see in endocarditis, and it requires a fundus examination to see that. Okay, so when you interview your patient, look at what is their lifestyle, whether it's IV drug abuser, or if the patient had recently had a valve replaced, or if the patient had a dental procedure recently, and so on. Now, when we do the physical examination, we talked about the specific symptoms like fever, because this is an infection, heart murmur in 85%, you hear that, again, which means that the valves are involved. In later stage, we talked about the nodes and the lesions. If the involvement of the valves is serious, you will see signs and symptoms of heart failure as a result of decreased cardiac output, such as fatigue. Now, the other symptoms that you may see in other diseases, they're not really specific to endocarditis, would be petechia. Again, this is because of the breakoff of the emboli and also a thrombi. Now, if you have a patient with a clinical manifestation that confirms or indicates that's endocarditis, and you see these symptoms, then it is related. Okay, now how do we confirm the diagnostic? Again, what we said based on the pathophysiology, we are thinking of murmur, and we are thinking of bacterial growth in the blood. So that will require listening to murmur, that will require echocardiogram to see the vegetation, and that will require the blood culture. Now, we have three major criteria, and the patient should have two of them to confirm the endocarditis, after, of course, the physical exam and the health history that make us believe that this patient has endocarditis. So two of these will be enough to say that the patient has endocarditis. Now, the blood culture, we send two sets of blood culture just for more accuracy, but again, the patient may show the blood culture may come back negative, although it's positive. It's called false negative. We'll talk about that. But if you see in echocardiogram, if you see vegetation, that's a confirmation of endocarditis. Now, if you don't see it, that doesn't rule out endocarditis, and so on with the new murmur. I'll talk about them one by one in a second. Okay, so with the echocardiogram, again, this is the test of choice to see the internal structure of the heart. Always, 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 the best non-invasive procedure or diagnostic test to see the internal structure of the heart is the echocardiogram. You will see if the patient has endocarditis and there's a vegetation, you will see in the echocardiogram, and this is like autopsy, where you can see that the patient has a vegetation, as you see here. Okay, again, if the vegetation is there, it confirms the endocarditis. If the vegetation is not there, it doesn't rule out endocarditis. Now, the blood culture, again, as we talked before, any culture must be a sterile procedure. It should be before the antibiotics if possible. And in this case, we do two sets of blood culture from different sites, again, for better accuracy. And if the patient is febrile, that's the best time to collect another blood culture. And again, if you have patients who's febrile after you start the antibiotics, it may mean that the antibiotics is not the appropriate one, or they haven't worked yet. So that's another thing to evaluate the effectiveness of the antibiotics, like especially in the endocarditis. After we start the antibiotics, the way we follow up to see, first of all, the symptoms should be subsiding, but the blood culture should, if it was positive, now it should be negative, and this way we know that we killed or eradicated all the microorganism. Now, in 30% of the cases in endocarditis, or in general, blood culture can come negative, although it's actually positive. It's called false negative. And the reason, there's some species like Bartonella, for example, these microorganisms are not detectable with all the techniques and the dye that we have so far. So, but we believe it's false negative because the patient has all the clinical presentations that enough to believe that this is endocarditis. So that's why if we have the negative blood culture, but you hear murmur and you see vegetation, that's enough to confirm the diagnosis of endocarditis. Other tests in CBC, you may see elevation of the blood cells and white blood cells, and you may see anemia. And rheumatic factor is found in 50% of the patients. We will talk about the rheumatic cardiac problems later. And if the patient's the condition got complicated enough and now the cardiac output is low, you may see signs and symptoms of renal impairment as a result of decreased cardiac output, such as a proteinuria. Okay, now the medical management. Again, think about it from the pathophysiology. This is an infection, but this is a serious infection. So for any infection, the treatment, or the any bacterial infection, the treatment is antibiotics. But in this case, this is a serious infection that should be treated, and we should eradicate all the microorganisms. So you will see that the difference here in antibiotics that we use multiple high-dose bactericidal strong medication IV for usually 4 to 6 weeks, for a long period of time. And you need to know that because you may have to explain that to your patients. So an example, you have a patient who's going to be on penicillin G with cefalozolin and gentamicin, a 3-strong medication for 4 to 6 weeks, and it's given IV because we want to make sure that we eradicate all the microorganism that is causing the endocarditis. If the valves now is not repair, or the valve is involved and there's some destruction, we may have to do surgical repair or even replacement of the valves. Now, because of the thrombosis, if we see vegetation, we may have to put the patient on some anticoagulants like Coumadin, or at least low molecular weight heparin, to prevent the chance of thrombosis. And this patient, again, the prevention always comes before anything else. Identify the patients who are at risk and teach them about all the strategies that can prevent endocarditis, basically in prevention of the invasion of microorganism. Now let's put together all this together as a nurse, what you need to consider. First of all, again, identify who's at risk and promote health through education of, quit IV abuse, and mouth care is important. If a patient is high risk, let's say a patient has a valve, every time they go to the dentist, they have to tell the dentist that they have a valve that was replaced. So a prophylactic antibiotic before any procedure should be done, and mainly if it's a dental procedure. You need to understand the manifestation of the pathophysiology and how they correlate and with the pathophysiological changes, and also you need to know the possible complication as a result of vegetation or as a result of the destruction of the valves. You need to do accurate assessment, and you need to know what is expected and was not expected, and always you need to report the non-expected as medical emergency. For example, let's say you have a patient with a tricuspid vegetation, and the patient now all of a sudden developed sudden dyspnea. Now this is most likely it's a PE that came from a vegetation from the right side of the heart. So this is something that you need to report right away. As far as Osler's and Janeway, again, these are not medical emergencies, but these are indication that of late endocarditis, and again, if you see them, that means that management is not effective. And so that's another thing, another point, that you have to understand the treatment, and you have to understand how to evaluate the treatment. Also, you need to understand the diagnostic procedures and where you see vegetation and what does it mean, and what could you see also in the IV in the blood test. And you need to know that because this is a very serious infection, the antibiotics regime is different. It's prolonged for a long time, bactericidal, IV medication, and the way you evaluate it depends that the patient's signs and symptoms are, they're disappearing or subsiding, and also when you repeat the blood culture, you find it negative. If you have a patient who's been receiving antibiotics and you still see that your blood culture keeps coming positive and it's accurately done, then that's an indication that the treatment has not been effective.